go ahead, Dr. Rybkin. And
Okay.
this is your pointer right there. And then if you want to down is
Right.
to go next.
Okay. Well, thank you for invitation, guys. Since I'm a thoracic oncologist here, I'm a thoracic medical oncologist. I do subspecialize in lung cancer and thorax, meaning I put it in lung, mesothelioma, thymoma, and esophageal up to the junction, including with stomach. So today's topic of the discussion would be precision medicine for advanced lung adenocarcinoma. I will be tweak that title from genomics because just preference, I guess, in terminology. Okay.
Down.
Oh, down. That's right. Well, let me just give you a very brief overview of lung cancer in general. So as far as histology, if you focus on this circle right here, so as far as histology concerns, there's two major groups of cancer. We call non-small cell lung cancer, non-small cell lung cancer, and small cell lung cancer. So small cell lung cancer is right here, and everything else is non-small cell lung cancer. That's easy. And then non-small cell lung cancer divided in much additional categories. And again, if you just major categories, adenocarcinoma, squamous cell carcinoma, and then large cell carcinoma. But then you have other 5%, but it's 25 or 30 or so. And one of them, more worthwhile to mention, is mixed histology, squamous adenocarcinoma. So why do we divide this? Well, back in the day before us, I guess, it was no difference whether you have what kind of non-small cell carcinoma you have. However, now it does make a difference for us, and me as an oncologist, I want to know exact diagnosis, not just simply whether it's a small or non-small, but I want to know whether it's an adenocarcinoma, or at least to say that it's a non-squamous, a non-small cell lung carcinoma, because it will affect my workup, it will affect my treatment. So now, as far as percentage, I would not focus. I guess that's a moving target. It depends where you are. If you're somewhere downriver or Detroit or downriver Detroit, you'll see 1%. Thanks to whatever environment and smoking, and if you're somewhere in California, that would be very different. But the idea is the same, that a small cell is diminishing right now due to decrease smoking, heavy smoking people, because this is extremely linked to the smoking. In fact, if I see someone who is a non-smoker with small cell lung cancer, my first question is, actually, is diagnosis right? And that's so that's my first question. And then yes, this is 1% of that non-smokers, and usually actually they're aggressive. So, but if we'll take a look into today, we'll focus on non-small and specifically on the adenocarcinoma, and in a second you'll see why. Well, I can tell you for small, there's no targeted therapy at this point. It's all chemotherapy. Shamefully enough, for past 35 years we use the same drugs, cisplatin and etoposide, and nothing, and not for the lack of trying. It's just a depressing field in a way, except for past few years where we start to see good signal in immune therapy, combined immune therapy, and I do use it in my practice in some of my patients, but other than that, it's still chemotherapy, sadly enough. So, but then in a non-small, what we see, I just briefly touch on the squamous. What you, just for you to know, that squamous cell carcinoma right now also no targeted molecular therapy, because very few mutations, driver mutations, and even these three which listed here, none of them are good actionable mutation, meaning that this FGFR receptors or PI3 kinase receptors, not this PI3 kinase inhibitor, this inhibitors do not show much clinical activity on their own, in contrast to what we see in adenocarcinoma. So, and that's why my rest of the talk will be focusing on adenocarcinoma, which is at this current state is most complex subtype of lung cancer and most prevalent. So, roughly a quarter of the adenocarcinoma is a KRAS positive, meaning that is, you remember from your medical school or biology class, so KRAS is a small GTPase, which very robust activator of proliferation and cell growth, and for which, like what Nobel Prize was given 40 years or 50 years ago, or something like that. But thing is, we still don't have any good molecule, any good drug to target that. It's just proven to be very difficult to target because it's very small, simple molecule, which is in a way make it very difficult to target, and affinity to GTP, GDP is extremely high, so it's very hard to compete with any compounds. So, but luckily for the patients, so other molecular mutations derived in the field, and where we have one big chunk is EGFR, and again, percentage is I always have a hard time to put a percentage on all of that mutations, because if we're talking about, say, Southeast Asian female never smoker, that would be very high percentage of EGFR mutation. And if you are talking about Caucasian or African American regular kind of smoker patient, that would be extremely low. So roughly, I guess in the Henry-Ford, from our experience, we see somewhere maybe about 12 to 14, somewhere there percentage. So, and then we have other mutations, genetic mutations, which are what we call activating mutations or cancer drivers. And let me just put that kind of term for you to understand, because if you ask me, is that all mutation what you see in this patient? No, not necessarily. In fact, many cancers will have, especially in a smoker, will have 200 mutations in one cancer sample. But most of them just what we call passenger mutations, and they have no any functional relevance in this cancer, and only this in a few cases where there's some particular mutation which is driving progression of the cancer, where you, by inhibiting this particular gene, that you will cause apoptosis and death of the cancer. So, and just to give you a summary of that, very brief summary, so in the field, that potentially actionable mutation in a non-small cell lung cancer, and most of that, like we just spoke, adenocarcinoma. So there's, what I did here, I divided them in 3 groups for you. One is mutations with standard of care medications. So many of you, I see, knowing when you hear EGFR and Lorlatinib, you already know about that, and that's great. And then these genes, but guess what? It's already 4 genes where we have actually FDA-approved medications for if you have this mutation, a particular mutation in these genes present, you can use certain medications. And you can see some of them actually have more than one, and some that we call like first generation, second generation, third generation, and then multiple lines of therapy in ALK and several in ROS1. Although Lorlatinib, it actually should be A. Yeah, Lorlatinib is it's a breakthrough designation. It's not yet approved, but we have, for example, I'm treating right now one patient with this because patient has one specific mutation on extended protocol, extended access protocol. So, but there are some also mutations with, and again, just a brief, not all of this, even if they are approved, that doesn't mean that they are approved in the front line, and you have to, in some situation you do, like in these 2, in some here, maybe not, but at least they're available for second line therapy. So then mutations, actionable mutation in different genes, like a MET gene or HEP1, hepatocyte growth factor receptor 1, RET and ERRB2, or other name of this gene is HER2, which you maybe heard from breast cancer. So it's the same gene, but different mutation though. And this actionable mutation, for this actionable mutation, we do have medications, but they are off-label. For example, they are approved for EGFR mutation like Afatinib, or Trastuzumab approved for breast cancer, or Crizotinib approved for the ALK positive non-small cell lung cancer, but Cabozantinib approved for thyroid carcinoma. So there's different. This is for BRAF inhibitor, different BRAF inhibitor from which are approved for non-small cell lung cancer, they're approved for melanoma. And then, I guess I have my fingers. So, and then we have a mutation, actionable mutation with early stage clinical trial development. So we develop still in clinical trial. Some of them have names, and this one I marked, like for example, we have trial here for these mutations. So, but if we go to specific, like I said, to FDA label, what is interesting, because if you look, and we'll look into more details at EGFR, but it's Lorlatinib, Gefitinib, and Afatinib actually approved only for specific two mutations. So not every single EGFR mutation, what we'll see on a gene, is actually could be treated with Lorlatinib, and the insurance has a right to technically may deny you. But most importantly, in some cases, it will be inappropriate therapy because these drugs have no activity for this for other mutations. Osimertinib is approved specifically for T790M positive EGFR mutation positive cancers, and after progression with any of these three. And then ALK mutation, we have Crizotinib, Ceritinib, Alectinib, and Brigatinib approved, and these two in the front line, but this after progression with like in this case, either or in this one, only Crizotinib. And some of that, you will ask, why is that specific? Well, some has logic, some not, meaning that the just trial was done a certain way, but say this one has more logic behind why we do this way. So then for us, approved Crizotinib, approved medication, and BRAF, it's the combination of Dabrafenib and Trametinib, and we'll go to details of that in a second. So just to give you an idea, because you're working here and you want to know what is, well, first of all, state of the art, but also what is the state of affairs here, right, at Henry Ford Hospital. So what we derived here with Dr. Stahl, who is a molecular pathologist, and me, we just sit down and kind of, okay, what are we going to do here? What currently with current available equipment and expertise, we're doing a next generation sequence for KRAS, NRAS, EGFR, BRAF, ERB2, and MET gene in one test. So next generation sequence, I don't know how many of you are familiar with that, but I'm sure you're familiar with PCR. So you can imagine as a multiplex sort of when you analyze many genes as more active genetically, what is hotspots of the genes. So it's a hotspots, which we call it's a region of a gene, which is prone to mutation over and over in through the population of many cancers. So because we have basic data where we say, yes, we know that exon 14 and the MET, for example, very common, either point mutation or deletion of that, skipping deletion of this exon, and then primers designed to cover this region, and then multiple primers for multiple gene design, and then you do one single assay where you can do up to 300 genes. Our analysis up to 48 genes. However, 48 genes actually, but however we don't analyze all of them, we analyze only this because that's where we will make a difference in the front line. So there's no point to waste money on other 48 other genes, especially they are rare and not actionable. So, but then that's what I just said. And then we, in addition to that, we do fluorescent in situ hybridization It's basically when you do under microscope, that's unfortunately a separate gene, unfortunately meaning that it's more time and more tissue required. That's why we like core biopsies. That's why we say give us more tissue from the pulmonologist for our friends, and we want more and more and more tissue. So, and fluorescent cytogenization, so we do four genes: ALK, ROS, rearrangement, RET, and MET amplifications. And in this case, you do probe basically one slide, one assay. So unfortunately, you cannot multiplex here. So we are in the process of moving to the one single NGS type of assay, as offered, for example, by Foundation One, Tempus, several companies who does everything, including translocation, rearrangements, and amplifications, and all these point mutations in one tube.
Igor, how much tissue do they need to do that?
Actually, it's about 0.2 nanograms, something like that. It's
so what we give you with like a TBNA.
Yeah, and that's what is key here. Yeah, like right now with bigger, better scopes, your TBNA you use what, 19 gauge or 18? Not what one?
21 is usually
21, right?
19 for example, 19 for molecular.
Right, and so we prefer 19 gauge. Well, the problem is it's always labeled as I guess because EPIC is outdated and it's labeled transbronchial fine needle aspiration, right? FNA, and that's a killer for me because especially I'm recruiting a lot for patients, as you know, for clinical trials, and clinical trials say no, we need core, and 19 gauge is a core. It is a core because what core is for histology, as long as it's not a diffuse spread of cells, but nice core, that is a core. It could be 14 gauge, it could be 19 gauge. So, and that's what we're trying to work on that so that it's labeled correctly. Where FNA, true FNA, to me FNA, it's like classical, like from ultrasound to thyroid, where you spread your some cells and no architecture, no histology to that. And that's make a huge difference for us because us is what we can and cannot do in interpretation of that. So for NGS, what is beautiful, that same amount what we used to do for PCR, one reaction, from the same amount you test all of these 300 genes. So that does not require, as long as, it's all like, reason why it's really difficult to answer this question because it's, what is the percentage of tumor cells in the sample, right? And that's where it's kind of nitty-gritty of that because like the pathologists, they look at that and say, okay, 20% of the sample is actually cancer. They do microdissection if needed, laser microdissection, destroy, surround and everything by laser, and leave only and scrape it and do all kind of stuff. One thing, but that's like you don't do often bone biopsy for the bronchoscope. So decalcification is a killer, but of course not an issue here. So let's just focus a little bit on the EGFR signaling transaction pathway. So EGFR is a epithelial growth factor receptor. It's a family of receptors. In fact, it's like EGFR, and it's field is very confusing. And the reason why, because the way it's historically developed, some people back in the age may discover receptor name one way, then another, his mother name or whatever, and then eventually we start to do nomenclature on that. But that's why you can see like HER2 is could be HER2, could be EBRB2. It's about 10 names, so that's why it could be very confusing literature. So, but point is, EGFR, it's a homodimerase, and what it's a tyrosine, intrinsic tyrosine kinase receptor, so they activate autophosphorylation of this receptor, and then activation of classical PI3 kinase pathway, and pathways to activate proliferation and protein synthesis for the AKT here, and for the RAS as well. So here's PI3 kinase. So, but also heterodimers of HER2, HER3, and HER4, they in the same family, but they role in a lung cancer. It's just immersion, and HER2 with different mutations in the exon 20. There seems to be a driver mutation, although amplification of this gene is under debate. Some people believe that it's just co-founder. It has no functional significance because data with clinical data, when we try to inhibit this pathway, HER2 pathway in our lung cancer patients, responses are sluggish. But question is that we're doing not a right drug, or it just pathway is not important? That's we still don't know. However, with EGFR gene, this is much more clear, or ERB1 gene, it's more clear, and we have clearly defined what we call classical mutations in EGFR TKI, also called sensitizing mutation, where we have either deletion in the exon 19, insertional deletion, or this point mutation in the exon 21, or a mutation in the exon 18. So that is a classical sensitizing mutation, but they are not limited. This is not only mutation which are responsive to the EGFR TKIs. It's just they're more common. That's why I have more knowledge. But it's just matter of that's when you have rare mutation. That's where it's default to kind of your expertise and knowledge what to do with that one. There's a very well characterized about 60 or so % of the patient who has these mutations and treated with EGFR TKI will develop specific mutation in a T790 called T790M. So methionine substitution at this position, and that make cancer resistant to first or second generation of the EGFR TKIs. So just to focus, refresh your memory. So I want to give you a sense of you as a pulmonologist, so make sure you know what, based on what as this EGFR TKI with frontline therapy was approved. So this is a composite of multiple clinical trials conducted over the years. You see this is names, this is patients, a number of patients, drug use, and you see it's either Gefitinib, Lorlatinib, or Afatinib, meaning either first or second generation. And control arm was classical platinum-based doublet, so historical, that's what is our standard of care at the time was, and still, if it's no mutation present. And response rate, look at that, response rate in a positive, and this is a positive, that's important, so this is a patient's positive for this sensitizing mutations. So look at that, so response rate is at least double. Because usually when I talk to my patient, I say to them very simply, with chemotherapy it's like 1/3, 1/3, 1/3. 1/3 will chance that it will shrink, 1/3 that it will be stable, and 1/3 that it will not work. So with EGFR TKI in the right settings, so you're going somewhere at least 60% or 65%, and that's impressive, as you can imagine. So progression-free survival was clearly improved and significantly, statistically significant, and that's meaning what we measure at time from initiation of therapy to the first CT scan or whatever, or death, or CT scan that showed that progression and confirmed progression, we have to change therapy. However, overall survival is no different, no statistical significant difference. So this medication we use as a frontline, and it's approved by FDA, but there's no proof that they have overall survival benefit. Well, why? Well, because no one will do trial, because remember, these people who progress on chemotherapy, they can cross over eventually to most of the time they can cross over to Loratinib, because that would be unethical to do, deprive them of that. Therefore, you do not see difference in overall survival. You can say there's a lot of studies done, cost-benefit benefit analysis, but truth remains the same. The truth is that people who is treated with TKI, overall they tolerate the therapy better. Not to say it doesn't have side effects, and especially one notorious, which we fear the most, is pneumonitis. And I see it? Yes, and it's very hard to diagnose. It's because there's no specific test for pneumonitis. Yes, sir.
I was going to say, how do you define response rate then?
Oh, no, what you do, to be included in the trial, this patient should have some metastasis, right, some masses which is measurable on a CT. And response rate meaning that what percentage of patients will have shrinkage of this tumor with that medication. So in a chemotherapy, say, just for sake of discussion on this trial, 32 out of 100 patients had a shrinkage. However, in a parallel arm where they treated with gefitinib, 62 patients had that shrinkage. Is that answering? So, and because of its less toxicity, and you bind these people high quality of life up front, so you're not saying because chemo will wear them off. It's always a matter of time how much chemo I can give even to the healthiest person in the world. Toxicity will be there at some point. And many of these people are already coming sick to you, and what you want to do that your therapy has a minimum toxicity, and they actually improve performance status and improve quality of life on the therapy, and then continue to live as long as possible. So, and that's, oops, gosh, that's a small thing. Just kind of small detail difference between first generation and second. That first generation was a reversible inhibitor of EGFR. Second was irreversible. Afatinib is irreversible. There's another one drug, I guess, Loratinib or something like that. But we drop it completely because there's no role with development of third generation. That kind of lost. Everyone lost interest in that. And second generation also inhibit whole that family. You remember when I showed to you these 4 receptors in that family. So second generation more on her family inhibitors, and it is beneficial in some of the patients when you have that non-canonical, non-classical mutations, when you need a little bit more benefit, a little bit more activity from your drug. So, and as far as medications, is gefitinib better than afatinib or better than Lorlatinib, first or second, there's no proof or disproof for either. So to me, all of them, as far as gefitinib and Lorlatinib, the same. Afatinib may have some more activity, but it has more toxicity. So therefore, I personally reserve it only for certain molecular mutations. So that's what it's probably the best choice for non-common mutation in EGFR. So, but again, just to give you a flavor of where we're heading right now. So recently, FLAURA trial was published, presented at ESMO, and where we compare third generation EGFR inhibitor versus first generation, regardless whatever you use, gefitinib or Lorlatinib. And so Osimertinib was developed against mutated protein in contrast to first and second generation. And turns out it has an activity against this T790M mutation. That's mutation which usually evolved during therapy with first generation or second generation. So in other words, you treat patients with Lorlatinib for 2 years or a year, and then cancer progressing, you biopsy and confirm that T790 is positive, T790M present, and you give Osimertinib, and they have a wonderful response for additional couple years. So that's a good thing. And that's actually make a brief point here for you that you'll see more and more that we request in rebiopsy. So this is something very new To me, like in my personal practice, I do it already for the past like at least 4 years or whatnot. So we biopsy quite commonly to understand what's going on molecularly. So in this trial, was showing that progression-free survival again with Osimertinib versus first generation EGFR TKI in the front line for patient who is mutant with classical mutations, or they have longer progression-free survival. However, this part of trial, and that's from ESMO, which was just like a couple months ago. Well, there's a small thing, hashtag here, and p-value is very nice, right? But with that hashtag, if you look to details, it's to achieve clinical statistical significance, a p-value less than 0.001 should be here, not 6, but 1 should be. So I think it's kind of should be shameful to me to show data like this, to be honest. I mean, because look, we're talking about human lives and you should not mislead physicians, right? So this should be cross-marked like this and say, look, this is not statistically significant, period. Because they did not, it's immature data, they're still maturing, they maybe will be positive, we don't know. But it's immature data at this point, and p-value is not statistically significant. I put NS, but it's like, so they have to be very clear about that. And of course, companies want to put Osimertinib to the front line. Personally, I don't use it still because reason for that, not only this, but most importantly, after Osimertinib, we don't know mutations which develop, and what I see in my practice, mutations which develop after that, we have no actionable mutation, we don't have any drugs, and then you have to go to the chemotherapy in contrast to Lorlatinib, where you can do 2 years here and then maybe hopefully a year and a half or 2 years on Osimertinib, so you're buying more potentially time until progression. But we'll see what overall survival will show us in a couple of years. So, and that was, I'll just skip that. So, and that's lead me to the trial, to this slide, where again, for you to give a sense what complexity we deal right now, because remember, we're right now talking just about one genetic mutation, one subtype of adenocarcinoma. And as data accumulate, what we start to notice that when we treat patients with first generation EGFR inhibitors, that's most data available, or second, what eventually cancer will progress, because stage 4 lung cancer is still non-curable disease. There's no question about that. And it's sort of like, think about that as an infection disease. If someone has HIV and not treated HIV, there's no way for you to, if it's not just HIV but AIDS, and you're not treating AIDS, there's no way to treat infection in this person, right? Eventually you'll breed bacteria which will be resistant to everything. That's cancer. That's stage 4 lung cancer right now. So eventually you'll breed some beast which will not respond to anything. But toxicity side effects are always there. And that's where challenge ours. So, but this is kind of current known mechanism of resistance, of escape of that sensitivity. Either, well, T790M I already mentioned, and as I give you 2 studies just to show gist of that depends on the study, depends on population. Some of them, they obviously the same, but some escape mechanism different, and point is we'll see all of them. So it could be one of particular of interest, small cell lung carcinoma. And that is very, and I saw it already in my practice when, say, 52 years old female from Upper Peninsula, she came to me and was treated with Lorlatinib and Osimertinib and T790M positive. And then she developed a kind of sort of progression. They sent to me and said, look, can we just radiate that, and let's just rebiopsy this, because that looks to me good, somewhat suspicious based on a CT. We rebiopsy, and sure enough, it was actually small cell lung cancer. And that's changed everything. You have to go to the chemotherapy. There's no target therapy for that. And we give chemotherapy in Upper Peninsula back, and then radiated after that. But then eventually, for some time with control, but eventually small cell lung cancer came back and just not control. And patient choose not to continue to fight. She kind of one of these UPS who likes freedom, good performance status. So, and she didn't want to do whole brain radiation and stuff like that. So, and that's one, or in other words, genes like MET, and now we have clinical trials, for example, here where we combine at the time of progression, we combine with MET inhibitors, or could be BRAF gene mutation, or MET amplification, or HER2 mutation, and the PI3 kinase. Also ALK, I don't see it here, but ALK is known, also could be a mutation in some of those cancers. Actually, interesting also JAK2, and again, that's and I have one patient with this mutation, which is same mutation for myeloproliferative disorder in the bone marrow or in the blood, but for some reason, because it's in the same kind of growth pathway, also we see mutations with that. So that will switch gears to ALK, signal transduction pathway, our next target. And again, point of this slide is it's complex. So ALK mutation completely different. They actually, to begin with, they are not point mutation like EGFR, but rather they actually fusion, fusion with different molecules, with different proteins. Most common is EML4 protein, but also other TGF growth factor and KIF5B protein could be fused to ALK. And what is here, for you to, again, to refresh your molecular biology, what this, you say, wait a minute, this is not, there's no mutation in the kinase domain. What happened here, simple, brutal force of overexpression. Because kinase like ALK, they're very tightly regulated by promoters and by cell. But what happened in this situation, it's fused to the gene, one of these, which is what we call housekeeping gene, which is constantly expressed in the cell. And then you have excess, simple, too much of ALK in a cell, and this kinase is, and that's close to the cancer growth. Again, Crizotinib, Ceritinib, Alectinib, and Brigatinib, like I said, there's currently available FDA-approved drugs. One of interest, just I want to share with you right now, in contrast, and I want to put a contrast with EGFR story. Alectinib is one of the new kids on the block, and it was recently compared in a phase 3 clinical trial when we combine Crizotinib, when we treat ALK positive patient either with Crizotinib or Alectinib. And look at that, no crossover per protocol here. So, because at the time, Crizotinib was actually a standard of care. And what we see in this trial, that, and I start from secondary endpoint intentionally here. So, but secondary endpoint, overall survival, so it's not clinically significant, although still data is still maturing, but nonetheless, there's not much difference. However, safety for Alectinib was dramatically better than Crizotinib. Crizotinib could be quite toxic medication because if it's oral chemotherapy, it doesn't mean that it's non-toxic. And Alectinib was overall better tolerated, and significantly so. But most importantly so, if you look at this, this is progression-free survival per RECIST criteria, and that's always a secondary endpoint. Primary endpoint was progression-free survival. Progression-free survival on by investigator assessment, and it was significant. I didn't put it here because I want to focus on this one. Time to CNS progression. And look at that. That Crizotinib underperformed significantly compared to Alectinib. And as a medical oncologist, I can tell you, ALK positive, something about ALK positive cancer, they very commonly present with a lot of brain metastasis, and they can devastate that, and it's usually young non-smoker guys. Or ladies or guys, people, patients. And we're talking about young population, non-smoker, physically active. I have one patient, for example, he is 48. When I was he hit my door, he was stage 4 disease with innumerable brain metastasis. He was 44, 43, and has just been a half-old child. And we treated him. Back then, told him Crizotinib. He's right now on Alectinib 3 alliance, and all these years he's playing golf, working, taking care of his child, so it's been great. So that's, but he's lucky we was able to control his brain metastasis in a good way. But usually what problems, say someone come in with ALK positive, not yet brain metastasis, but then they develop brain metastasis, even on Crizotinib, because Crizotinib has a very poor penetrance to the brain. But Alectinib, on the other hand, has excellent penetrance to the brain, and that time to CNS progression, meaning performance status, quality of life, is you're gaining a lot. And in contrast to Osimertinib, despite the fact that there's no overall survival benefit on this trial, it was adopted by NCCN. FDA still didn't approve as a front still, but by NCCN guideline, adopted as a front. And I also, when I teach and when I talk to my colleagues, I say I use it as a front line, because you know they will have high probabilities of brain mets, and that's a huge benefit here. So what is the mechanism of resistance of ALK for ALK TKI inhibitors? And again, where is here we start to see, actually very interestingly enough, we start to see point mutation in that truncated protein within kinase domain. So that actually this, like I was showing to you, is basically you take a wild type ALK TKI kinase, like C-terminus, right, and fuse it to, in a primate, on the N-terminus you fuse with this housekeeping, whatever ML gene, and that becomes constantly it's just present all the time in the cell. But now this present all the time fusion protein, this gene, starting to develop actually point mutation under selective pressure of your Crizotinib or Ceritinib. Right? So again, it's going back to kind of your evolution, selection, pressure, and microbes, I guess, most convenient example. So, but also not only this, could be amplification of ALK, just even further amplification, genomic amplification, or increased EGFR signaling. That's an interesting one, right? Or IGFR, insulin growth factor. What it means that it's actually, and that's when I first read that paper, it's kind of disheartening, because we're talking about on a protein level, not on a RNA, not on a DNA, on a protein level, they have more phosphorylation. I said, well, how are we not detecting this whatsoever? We don't test it. It's still in the lab. Our clinical medicine, we are not prepared for like mass spec and all that. We're not there yet. But knowledge is there already. And so then KIT amplification and some other genetic mutation were described, but they're not yet validated whether they are actually. Like MET, it's not listed here. MET is validated at that point now that hepatocyte growth factor, or MET, is one of the mechanisms of resistance for TKI. And that's again to the point why you see, like, we send it to you for rebiopsy, and why it's like sometimes I ask, what do you want to order? I said, you know what, tell me when biopsy, I will order what I need. I need to know when biopsy is, and I'll just order what I need. Because I'm very specifically looking, not just randomly fishing for something, although sometimes you do, but that's like when you run out of everything you're looking for some clinical trial, but most of the time you're looking specifically. Here's an interesting table, and you don't need all details, but what I want to show you that out of this Crizotinib, Ceritinib, Alectinib, Brigatinib, so this is 4 FDA approved medication. There's one mutation called this, which formed under selective pressure. It's G1202R, which only responding to Lorlatinib. I have now a lady, she's 44, mom of 3, from Canada, from Windsor, and she never smoked, kind of yoga type of thing, you know, like she's very fit and everything. And 2015, she was diagnosed with stage 4 lung cancer. She came here for screening. She gets in treatment in Canada mostly, but I see her on like every half a year or so in kind of direct treatment. And so her cancer was very odd behavioral, because it was responding to Crizotinib, but never to the full response, kind of heterogeneous. And that I keep saying in my note, I said, look, it's kind of heterogeneous. Then it's progressed, we changed to Osimertinib, then progress again with brain. We have to do SRS, we have to do whole brain radiation, and then chemotherapy. Then we changed, Alectinib came aboard, and we were able to treat an Alectin progression. And then at that point I said, look, now we have new data. Lorlatinib back then was not available, but recently it's just, because it's a very new medication, it's still not approved, it's not available, but it's only through the it's a breakthrough designation, and on expanded access protocol you can get access. We're doing biopsy. I sent to our pulmonologists, they did biopsy from one of the places where actual growth, and that's again where I'm working very closely with my pathologists, with pulmonologists or interventional radiologists. Let's say I do a PET, and I say, you know what, I call to my pulmonologist and say, look, I need that part. We see that don't take this, which is not as bright, but take that, because that's a troublemaker, and that's what I need analysis of. And sure enough, that came back positive as G1202R, and that's I think she always had that clone. I think that's always had, because she's like, it's never been true homogeneous response. So we opened protocol just for her, and we just started like literally a week and a half ago. She's in so far tolerating well, and most importantly, they tried to, because she progressed with new brain metastasis, and I was trying by every means avoid that re-radiation, because they can have severe side effects when you re-radiate a brain, and in this age it will be devastating. And we started therapy. After a week of therapy, they still simulated just in case, but when they start to simulate, meaning they did repeat MRIs, I said, you know what, they're shrinking, everything's shrinking, so we cancel radiation. So she will be just on Lorlatinib right now. So hopefully she'll do fine. So, and this is what breakthrough therapy designation, and for anyone, if you have this particular mutation, and that's what she has, and that's why I was approved that trial here. But right now, there's some trials to approve it. That is an interesting slide for you to see what it is. Point of this slide, and Alice Shah, she published this in New England Journal of Medicine. It's interesting, right? One case, clinical case, made all the way to New England Journal of Medicine. And the reason why, so look what happened here. Biopsy was done to this young patient. It was ALK positive. Back then, was treated with Crizotinib, whatever was available. Then biopsy was repeated at time of progression, recurrence of cancer. Osimertinib was given, so nothing was found, but Osimertinib was given. Then some sort of compound on the trial. Then they run out of options. They do chemotherapy, progression. They run out of options, nothing. You do something. You do Crizotinib. Didn't work. But then they biopsy. Oh no, they did Lorlatinib. That's because that's phase 1 trial Lorlatinib. Some response, but then again progression. They biopsy. But when they biopsy, they realize that in that chart what I showed, Lorlatinib will be not active. It's active against this rare mutation, but not active against other, where Crizotinib is active. So, and they switch back to Crizotinib, and now they have response. So you see that liver with all this meds, and now it has response. That's the case. So that's why we biopsy. Now, especially for ALK, there's no as such first generation, second generation, because they go either way, depends on the molecular mutation. it's fascinating. It's very complex. So, but that's why we. And they can come to you and say, "What you can do after that?" You see, you already progress. No, you can. And like I said, like guy who's 48 and his kid right now knows him and running around, or this mom of 3, right? That's I don't know what price for that, 3 years or 4 years or 5, maybe, because right now I just saw that guy just this week and ED, no evidence of disease, just not. Granted, we tweak, like I said, what we did, we really cheat me, well, in a good way. So I radiate his primary cancer because that was all kind of persistence that was just radiated 2 years ago, and then it keep all quiet. And we ablate the liver with Scott Schwartz ablating liver, 1 lesion, and yeah, for past 2 years nothing. He's like everything quiet. He's on Alectinib and doing well. So that just give you. So now very briefly. Since we start a little bit late, but as far as ROS signal transduction, so this is a signal transduction for us again, and it's sort of alphabetic soup. When I remember when I was just started to do signal transduction in my PhD, I get scared to follow that. But they said, look, don't worry, you'll get used to it, and that's true. So my point is, a bunch of kinases or whatnot, and the GTPases and stuff like that. Point is, all of them lead to some degree to proliferation, either blocking up apoptosis, death, right, or the growth, protein synthesis, or DNA synthesis, or both, or some of them. Right? And again, ROS is an animal where you have gene where you have rearrangements. We know pretty much only one I saw article so far where MET as a mechanism of resistance. This is very new data, and we're just learning. We still don't know what ROS mechanism of resistance would be. So that's, but we already have this Crizotinib available to us, so which will be already approved by FDA for ROS1 positive based on the phase 1 and retrospective analysis. And you say, why? Why FDA approved on the phase 1? Well, we knew error, and it's exciting error, because look at that response rate. Now you expect medical oncologists, right? You expect, it was 30%, 25%, right? And look at that, 72%. This is signal too strong to ignore. Yes, phase 3 data collected, we're doing trials, but some people who has no access to the trials, we need to save their lives. So, and BRAF, last one is Dabrafenib and Trametinib. This is BRAF is also will be very complex story, because BRAF is a big gene, and mutation, first was discovered mutation important in melanoma, and successfully used BRAF inhibitors, and it was mutation valin 600E, so the V600E, then what was found, especially in lung cancers, is not only a V600E but other mutations. And what we don't know which one of them actually responding to this mutation or not, because in vitro data showing that not all this mutation equals. So some of the inhibitors, there's about 4 to 5 BRAF inhibitors, and they're slightly different, and some they responding to different mutations differently. What I notice in my personal practice and that's kind of reflect what literature suggests, that BRAF actually you see in the smokers. And the elderly smokers, that's what I see as mutations. That's interesting. So that's, and if the FDA recently approved use of this combination based on phase 2 non-randomized three-cohort study, and it was based on a cohort C. It was chemo-naive. Treatment was Dabrafenib and Trametinib. And again, only 36 patients. I mean, shameful, I know. But it's not your cardiology, right? But like 10,000 patients, right? But that's how it is. It's just rare cancer. And yet we need to move and benefit these people somehow. And here they have progression-free survival was partial response 45, and partial response we define by RECIST criteria. It's international criteria, meaning that at least for 30% reduction at least to confirm CTs in a distance. So, and complete response meaning that you cannot see anything on the CT anymore. So, and based on that was approved for treatment. Again, just this is your MET exon 14. I have these patients as well. They also usually elderly, maybe some history of smoking. However, last week, 2 weeks ago, although the results came like this weekend, I diagnosed one lady who was 72 or so. She's Filipino, never smoker, and coming walking in with stage 4, and pelvis, basically left part of pelvis gone, and because of metastasis, and but doing great. She said, like, are you saying to me like I have to stop dancing? I said, yeah, for now at least. She's still dancing, and like, please don't do it now. Like, there's no pelvis there, and like center aorta, all that stuff. And I suspected, I said, look, you have some sort of mutation most likely. I thought EGFR, that's sort of my, and we sent her to blood circulation tumor ctDNA for analysis, and before we even have histology, I got result back. It was MET exon 14 deletion, and that's characteristic for sarcomatoid adenocarcinoma, which I told you other sort of. It's rare. It's about 7% of them, or whatever the number is cancer, sarcomatoid non-small cell lung cancer. But in that group, percentage of MET deletion, exon skipping deletion, is big, and that was not surprising. So, and I started her this week, Monday, immediately on Crizotinib, so instead of chemotherapy. So that's how it, and it required me, and yes, it was conversation with pathologist on Saturday, and email was sent to me from outside company who the Guardian 360 who was positive for this mutation, and I immediately put order, and we started immediately on Crizotinib. So final remarks, sort of paradigm of driver mutation now as well in clinical practice. It's extremely rapidly developing, like the Loratinib for BRAF and for Lorlatinib that are approved like within past 6 months or so. So all of that. So it's Osimertinib was approved for like last fall. So it's extremely rapidly developing field. And again, it's your basic biology, evolution. So under selective pressure, they start to eventually develop some sort of escape mechanism from your therapy. And it's important to learn about some of them more or less predictive, but never 100% predictive or even close to that. Like 60% will be predicted for T790, but some, like in the ALK, completely unpredicted. So you have to rebiopsy. And some, like for us, we still don't know what they are. And then, that's what I just said, novel detection technologies are still needed, because even with NGS, they're far from being perfect, and there's some publications, again, a very technical publication where, so in our literature where we're showing that some of the mutations in MET gene are not detected routinely by even Foundation 1 or some other, so we're missing some patients because of region genetically complex. And of course, well, as far as amount of material, we're pretty good now. We don't need that much. So like usually 2 to 3 core from 19. Yep, we're done.
I'm sorry.
Yeah, and